Indy. Great, thanks Frank, thank you.
Yes, good morning. I think the microphone should come on. Yeah. Thank you to the organizers for inviting me and giving me the opportunity to speak to you. I hope you don't regret it and find it interesting what I have to say. So, this is our team of social prescribing link workers, hard at work in the office just yesterday morning. And just briefly, the background of our social prescribing pilot is that it was part of the Equally Well strategy in Dundee, being one of 8 Scottish test sites. I'm not the expert to talk about this, but the interesting bit is at the bottom. We started as a pilot practice from March 2011. Initially it was meant to be for 4 months, which I actually only discovered a few days ago when I prepared this. Well, it's still going on, which is brilliant. I thought I'll do a short version just in case somebody wants to rest their eyes at this stage. Social prescribing is great and we need more of it. It's quintessentially what I'll be seeing in the longer version of this presentation. Yes, why does general practice need social prescribing? I think part of it is that as societies have become more fragmented and have lost their community focus, GPs ended up in this more pastoral role for which we are all poorly equipped through medical training. We've acquired this role by default. So we started from here and we ended up there. Social prescribing helps us to manage complex consultations with a psychosocial background a little bit better in the 10 minutes we are given with the patient. Gives us in a way a bit of a focus. In my opinion, link workers could become instrumental in working alongside practice nurses and GPs to help overcoming barriers to help behavior changes. I think it would benefit not just one, but all long-term conditions a patient have. It would lead to a more holistic and patient-centered approach rather than the current quite siloed and paternalistic way of delivering chronic disease management. I thought I'd throw this in. It's from a book by Richard Wilkinson. He's given me permission to use it. He calls it epidemiological transition, which really describes the paradox as material wealth increases, life expectancy increases, but then it plateaus out. So there's not much difference between Costa Rica and the United States, even though they have 4 times the GPC per capita. In my opinion, social prescribing is the best tool, or one of the best tools, to reduce health inequalities within communities. I'm now going to speak about how we in practice deliver our social prescribing scheme. At the beginning of the project, we came up with a list of people who would benefit from psychosocial support. Mental well-being which is affected by social circumstances, vulnerable and at-risk groups, in particular single mothers, carers, patients on low income after bereavement or unemployment, mild to moderate depression and anxiety, chronic physical and enduring mental health conditions, and finally, frequent attenders in primary care. Ultimately, it is really everybody, as we all benefit from feeling part of our local community. Some people may be more cynical well, this is an opportunity for GPs just to sit back, put their feet up and count their money. But we are still left with the more challenging patients. Patients in acute crisis, acute psychosis, or with severe depression. Patients who are acutely or actively suicidal. Patients with substance misuse issues as their primary problem. And patients where there's concerns about the safety of the lone working link worker. At this point, I would just like to point out at the sentence about substance misuse. We did quite deliberately decide not to make it an automatic exclusion. We found that these patients often fall between the responsibilities of services. A GP assessing a depressed patient would often use methods learned in psychiatry and assess a patient accordingly. He would identify symptoms of depression according to the biomedical model. This unfortunately would lead to a prescription of an antidepressant and make a social prescription difficult or impossible. To enable a consultation with the patient about a social prescription, it's important to take an interest in him or her as a person, find out about their family circumstances, their skills, hobbies, past achievements and hopes for the future. This then enables a smooth transition to offering the patient community-based non-medical sources of support. Interestingly, in the middle is what the current new GMS contracting quality outcomes framework asked for. They termed it the biopsychosocial assessment. The only difficulty with this is how to do it in 10 minutes. When we first started out, the project was literally called social prescribing, but we realized it wasn't really a very helpful term and patients found it difficult to really understand what it meant. The renaming of the project into Sources of Support reflects this need for more descriptive branding. The link workers also came up with this quite helpful social prescribing script. When the project was rolled out to 3 more practices, it was obviously a new concept to the GPs there, and this was to act as a guidance for them how to start a conversation with the patient. You'll obviously get that if you want to reuse it. I don't know if there's a copyright on it. Sheila shook her head, so no, you can use it if you want. So after we'd been going for a while with social prescribing and reflecting on it, it was really quite important to work out why some patients engaged with it and some didn't. I think part of it is it's new and you need to have a trusting relationship with the patient. It helps if you've seen them before and it helps if you've known them for a while. Then they trust you to try something new. Previous experience comes into it. Patients often came into the consulting room and expected to be given an antidepressant. And when I started to talk about money and friends and family, they looked at me a bit puzzled and were wondering when I would get my prescription card out. And it's part of the process is really to re-educate the patient almost, that there's more to feeling well and happy than just tablets. And now it's been going on for a few years, I can really see this isn't so much of an issue anymore. Patients are quite good at accepting that it's not tablets. And patients who come back who've previously been through the social prescribing scheme, which quite refreshingly, well, for me it's very refreshing, they actually come in and they sit down and they say, I don't want antidepressants, and then they start talking to me. It's really wonderful, actually. Yes, and as a social prescription and referral to community resources involves maybe going out of your comfort zone a little bit, I think the patient's confidence and self-esteem come into it, and I think the poem quite well illustrated that earlier on. From my perspective, the benefits of social prescribing, there's too many to mention, but just to name a few. Patients come in, they really look and feel like they're carrying a heavy load. Complex consultations, often termed GP heart sinks. They feel like this, trying to unravel a big knot, and you just can't do it, and you feel like slicing through the middle, but that's obviously not an option. Initially, we had a 2-week response time, which we thought was quite important to pick up the patient when they're motivated, when they've asked for help, and it did work well. Unfortunately, we are now up to 3 months waiting list, but it's hopefully going to come down again soon. It helps to have a bit of support for the patient. After I've seen them and referred them to psychiatrists or psychologists, and they know they're going to be waiting for a month or 2 or even longer, it helps to know you've not just sent them out into the wilderness, but there's somebody else who's going to support the patient. And this does mean they come back less to see me. One important bit, which I think is always something that comes up with community resources, is how to know about it, what's out there. I would say probably takes about a year for a GP to find out about a new community resource. And if they have limited funding at that year, they're about to phase out, and GPs start to refer in when the project is actually ending. And just to give a brief impression of what it's like, this is Dundee, and it's probably not an all-exclusive list, but that's everything we should know about, and we just can't. So to have an expert like a link worker is brilliant. I find it's been good for me and the patient to see that real change is possible, and it's given me and my patients hope, I think. This is what happens after the referral to the link worker. They get up to 4 consultations and a final evaluation session. The initial consultation certainly can last up to 50 minutes, which is an awful lot more than I can offer. Regular review of progress gives repeated opportunities to address issues, think about how the patient wants to move forward. The timescale of these follow-up sessions is entirely dependent on the patient and their progress. Ongoing contact and offer to escort them to community-based activities in between consultations. On average, I think we've just recently discovered last night from the data analysis that it's on average between 1 and 2, but can be up to 5 supported visits. This is a patient's perspective of the whole process. She was a young woman, single mother, finished school without any qualifications, was struggling to look after her 2 young sons. One has been diagnosed with ADHD. She had financial difficulties, was homeless, living in a network flat. She went through the social prescribing twice, once there and a second time just recently. And she has gone to college, has done her standard grades, was planning to become a paramedic, Unfortunately, she was hit by rheumatoid, but she's battled through it. She's off antidepressants, and she's developed an incredible amount of resilience. I don't think she would be where she is now without the social prescription. Yes, where from here? There's been a rollout to 3 further practices in Dundee. From the initial 2, there's now 4 social prescribing link workers. We continue to offer GP practice and community-based consultations, and the referrals come from GPs, practice staff, patient self-referrals. The majority of referrals are just still GP referrals. And we're planning to develop ways to target or identify and target deep-end patients within our mixed practice populations. Challenges early on, I would say finding patients. Now it's too many patients. Because initially I would wonder maybe, or refer, say, out of a surgery of 20 patients, maybe refer 1. Now I could literally refer almost every single one, because your point of view just changes. You know. Getting buy-in from colleagues initially was a problem, but a presentation to all the colleagues really changed this. What we did, we presented case studies, and that changed everything. Funding is always an issue. We would like to roll it out, but how do we do it? This was the evaluation, the only one that's been published so far, but the second one is on the way. This is the link to it. And the take-home message is this.